Okay, so what are the relevant measures in sleep? So this gets to the heart of what defines quality in sleep labs. Sleep lab process measures. Here are just some of my suggestions. I mean, you can come up with some of yours. I mean, I think what you should, if somebody asked you to come up with 4 measures that define quality in your operation, what would you say? Well, you might say something like, I'm interested in measures that reflect how well my patients get into and out of my laboratory. So you might say, look at no-show rates. Or I might be interested in how happy patients are with the care that they received at my hands. The things that I do, are they happy about them? So I might look at satisfaction scores. And this is probably the most basic things. Satisfaction scores have been around a long time. They're a process measure. They're very important because patients, if they're not satisfied, then something has to change. But you might also want to look at your own operations and say, I'm interested in things that show that my staff is very efficient at what they do. So, for instance, how quickly I turn my sleep studies around. I want the percentage of studies completed with scoring and interpretation, let's say in 48 hours after the study is completed. Or I might want outcome measures that reflect the quality of the work I do. So I may look at inter and intra-score rate of reliability, something that the American Academy of Sleep Medicine is very interested in, to show that I'm good at what I do across the pool of workers that I have, and that the workers tend to be consistent over time. So those are very important things if you're in the business of having human beings do a certain work, a certain type of work. You want that work to be similar between the people doing the work, so that when Frank is off and Mary has to do the work, that Mary does things in a way very similar to how Frank does it, and that a year ago Frank was doing things at this level, and that now he's still working at that same level, or maybe even higher. So again, these are things that reflect accuracy. And so if somebody asked you to come up with good process measures that define what you do, you might think about some of these things. Sleep lab outcome measures. What are good outcome measures in the sleep lab for diagnostic studies? I think it's hard to think of relevant outcome measures for polysomnography or home sleep apnea testing for the diagnostic study itself. Most things that we think about, in my mind, about doing diagnostic sleep studies are process measures. Let's talk about the same question for therapeutic studies. Sleep lab outcome measures for therapeutic studies. Here I think it's a lot easier. How many studies had a final apnea-hypopnea index less than 10? Less than 5. What were the percent of patients that accepted CPAP therapy based on the study you did for them? What's the percent adhering to CPAP greater than 4 hours per night? What is your rate of improvement in the functional outcomes of sleep questionnaire? What is your improvement in the psychomotor vigilance test? Probably not many of you use that. It's not really too much of a clinical tool, but it could be. There's enough evidence supporting it to make it a clinical tool if people wanted to use it in that way, etc. So there's lots of different things you can think about on therapeutic studies that have outcomes. Whereas I think on the diagnostic testing side, are there really outcome measures? Are they more process measures? You know, you had the sleep study was technically adequate, let's say. I sort of view that more as a process quality measurement more than an outcome measurement. Okay, so let's talk a little bit about portable monitoring. As I said before, I sort of prefer the term home sleep apnea test, just so I can be a little bit different from other people. Why do I like that? Well, portable monitoring is vague. What is being monitored? Portable, what does that mean? You're walking around with it. Ambulatory monitoring is worse than portable monitoring because you're not measuring anything that's ambulatory. Home sleep testing, which is the CMS term, if you look at in the national coverage and local coverage determinations from the government, they use HST, home sleep testing. There is no sleep being tested in the home. There is sleep apnea being tested. Limited channel testing. I think that's better, but what are the channels and what's limited? And what are you testing? What you're testing is sleep apnea in the home. That's my soapbox. As I was developing this test, I knew that the other speakers were going to cover everything from the beginning to the end of we'll call it portable monitoring, because that's sort of the more conventional term, or home sleep apnea testing. So I sort of stayed away from things that really are describing it too much. But certainly it is not new. It's not some recent innovation that occurred in Europe and has been imported to the United States. It's been around since the late 80s, and there is actually a very large evidence base for it or against it, depending on how good you think that evidence is. But it's certainly not new, and its use has slowly been increasing since 2007, 2008, when CMS said, okay, we will be paying for it in the context of all the things you've heard about earlier today. So what are the key measures for this modality of testing? What are the key measures for home sleep apnea testing? Well, we can think about this context of process and outcome measures. If you look at process measures, I think something like the percent of successful tests. We've all heard about, the rate of inadequate tests in the home setting. That can be a real problem. If it's too high, you become very inefficient and it's sort of wasteful. You'll waste money by having to do too much retesting. So you really want to get it right the first time. So you want your percent of successful tests to be high. Percent of devices returned, let's say in 72 hours. So you have patients who take these devices home, and if they don't bring them back, then you can't use that device for somebody else. So if you're in a commercial market, then that is loss of revenue because you don't have the equipment to do the testing. Percent scored in 24 hours. I mean, if you're not efficient in turning this work around, then patients will be unhappy and they can go somewhere else, or your people referring to you will get grumpy because they're not getting the reports quickly. In terms of outcome measures, well, I think the one that makes the most sense to me is what's the percent of tests that are positive for sleep apnea. That's what you're looking for. And if you're doing a lot of negative tests, then okay, but what you're really interested in is case finding for OSA. And maybe there's some others that you could come up with. I think if we sat around for a few minutes, we could come up with some others. But this seems to be the most relatively important one to me. So what about polysomnography versus home sleep apnea testing? Because I was asked to talk about both entities in this presentation. So I would say the things they have in common are that quality measures for both focus on processes of care and process measures primarily. And you want the processes that you develop by which the care is delivered to be excellent. And you've heard presentations this morning about kind of how to give excellent care, or you've heard models of what people perceive to be excellent care in home sleep apnea testing. So you have some framework now with which to go out and do this kind of work if you're not already doing it, or maybe make changes to your program if you've already started. And then I would ask, is there a scenario where a positive PSG and a positive home sleep apnea test would not both lead equally to a treatment study? So if you have a positive PSG, you're going to take that as diagnostic. And I would ask you, if you have a positive home sleep apnea test, is there a scenario where you'd say, oh, well, this person has a RDI of 35 on this home test, but I don't believe it. I can't really envision a scenario where that would happen. You might say, well, this guy, we know he drinks a bunch of alcohol right before he goes to bed. Okay, maybe that influenced it some. But you would still believe that the test had some validity. In other words, I think for home sleep apnea testing, my question is do false positives really even exist? And I don't think they do. I think a positive test is a positive test. And I would say home sleep apnea testing then is on par with polysomnography in that sense, because you would not take a polysomnogram done in your lab, which shows an AHI of 40 and say, false positive. He couldn't possibly have sleep apnea. No, because you'd say, hey, sleep apnea is sleep apnea. And I would argue that for home sleep apnea testing, the same rule exists. So we have a positive study is a positive study. Sure, things can influence it, but it's still positive. In terms of outcomes, both tests lead to treatment, and it's the treatment then that becomes the main interest. And then, so what you really want to ask is, are the treatment outcomes related to CPAP therapy, whatever therapy you're talking about, are they the same? So the treatment outcomes, in my mind, are the same regardless of the test used. In other words, the diagnostic route that you use to justify treating a person for sleep apnea has very little bearing on the outcome of the treatment that you are delivering. Let me say that again. I don't think that the test you use now, I think there's ample evidence now that says it doesn't matter how you diagnose sleep apnea. Once you've diagnosed it, treatment proceeds from there, and the diagnostic testing does not influence the results of therapy. And there are at least 4 studies which support this. Richard Berry's study using the WatchPat in 2007, randomized trial showing that making a diagnosis with the WatchPat led to certain number of positive diagnoses, and those people went on to use auto CPAP effectively. The famous Mulgrew study from British Columbia, published 2007, did a 2-step diagnostic process. The treatment outcomes with CPAP at 3 months were the same, regardless of whether they did a in-lab evaluation or this sort of out-of-lab diagnostic approach. A less well-known study published in 2010, Skomro and colleagues from Saskatchewan, again, a randomized crossover trial design in a small study, a small number of patients, showed equivalent outcomes irrespective of how the diagnosis was made, whether it was some sort of home testing that they did or lab testing. And then a study that I'll describe more in a minute that I've completed with my colleague, Dr. Sam Kuna, looking at a randomized trial of a completely out-of-sleep lab approach to diagnosing and beginning therapy for sleep apnea versus the typical in-lab approach. No difference in outcomes at 3 months, and we'll look, we'll have another paper looking at probably 1-year outcomes, but my guess is they won't be any different. So I don't think that the diagnostic route matters now. You should do what you need to do, what you can do, what you're allowed to do, what you financially can afford to do, and then focus on the therapy and getting the best outcomes from the therapy. So what are the key outcome measures now? Adherence, some sort of functional outcomes assessment or quality of life measurement. There's a number of well-accepted, validated instruments that can be used for that. Functional outcomes of sleep questionnaire, the sleep apnea quality of life instrument. And then I think there are some emerging outcome measures that some of these will pan out, some of these won't. But I think things that are coming down the line that'll be interesting will be things like simple things like blood pressure. We know from large clinical trials and then the accumulation of or putting these these different trials together in meta-analyses. 2 meta-analyses have been done, both of which showed positive outcomes on blood pressure from the treatment of sleep apnea. There are a number of biological markers in the blood or other parts of the body that change in response or may change in response to effective treatment of sleep apnea. There are a growing number of vascular biology markers. This sort of gets back to the blood pressure story, but there are things that happen in blood vessels in response to sleep apnea that you can reverse with treatment of sleep apnea. You can measure those. We don't really measure them clinically now, but it's not something, these are things that in the future might be relevant. So what a dream situation would be is some sort of robust, accurate measure, easily made, that would show that sleep apnea therapy has been successful independent of patient self-report. Because patients are subject to all kinds of psychological biases and placebo effects and things like that. We know from placebo-controlled trials in sleep apnea that people who get placebo oftentimes feel quite a bit better. But it may not be helping their abnormal biology. What you'd like is an independent biological measure that shows this is sleep apnea before, this is sleep apnea after treatment, and this is better, and this difference has meaning to the health of the person. We don't really have that yet, but hope with some luck and some hope we will have it one day.